Thank you very much. I must say this has been a really terrific session today, and I really appreciate the opportunity to be here. And I also hope I got the active slide changer, not the placebo. Well, I guess we'll see. It's the other one. So a little bit of background. My interest has been in comparing coronary revascularization methods. These things are incredibly common procedures. There's over 1 million of these done every year, especially if you look worldwide and not just in the U.S. Angioplasty is a way to get at fairly limited disease. You use a little catheter to open up a vessel and put in a stent. Bypass surgery, you open up the chest, you get past a lot of obstructions, but it's a big surgical procedure. They can be used as alternatives for various kinds of coronary disease, but they're mostly is an argument about which one is better whenever you have coronary disease that's sort of in the middle of its severity. It's not too limited, in which you'd really not seriously think about surgery, or too extensive that you'd really not think about angioplasty. And it's really uncertain about the relative effectiveness of these two procedures, which are used a lot on mortality. And so there have been various ways to study this question. There have been randomized controlled trials that have been done, quite a few actually have been done, comparing PCI and CABG, and some of the people in this room have been involved in doing those studies. Then there's also observational studies where various data sets have been used to compare these two procedures. But almost all of these things have focused on the overall comparison of CABG and PCI in the entire population, getting an overall summary estimate of their comparative effectiveness, not on how much they might differ in different segments of the population. One important observation is there is some evidence of heterogeneity of treatment effect, in that one of the early trials of bypass surgery versus angioplasty, the Berry trial, showed that there was a much greater effect in patients who had diabetes than in the people who didn't, favoring bypass surgery. Now, this is a very controversial suggestion that was followed up by a lot of different other kinds of studies trying to replicate this particular finding. We've already heard today about the concerns about subgroup analyses that have been done. And this one was one of them. There's concerns about just being on a big fishing expedition for differences in these post hoc tests. Then there's questions about what the proper method is to do. One thing that is not favored is to just look at the p-values in the two groups to see whether one is significant and one isn't. The favored way to look at this is to look and see at the two groups, do you have positive evidence that the treatment effect in one group is different from the treatment effect in the other group, a difference in the differences? And that's a more difficult test to meet, a treatment by covariate interaction test. The corollary to that is that you need much, much bigger sample sizes to look at heterogeneity than you did to look at the main effect, because you're trying to look for more subtle differences. And the other thing about it is that it's actually a lot simpler to just take the overall answer and say, let's just apply it to everybody. So this treatment beat that treatment, so everybody should get treatment A instead of treatment B, instead of, well, these people should get A and those people should get B. A lot harder to implement and come into policy things. So in order to look at this question of heterogeneity, one could look at it a couple of different ways. And one way to do this that is possibly helpful is if we think that randomized trials are the best way to look at this question, but each one of them is sized only to look at the main effect, maybe the answer is to pool together a whole bunch of randomized trials and then see what the answer is in a larger sample size to see if we can see differences in the treatment effect. So we did organize a collaboration of 10 randomized trials of bypass surgery and angioplasty and convinced people to share their data, which is much more a political problem than a technical problem, although there are technical issues in terms of pooling the data. And the advantages of having individual data is that you can do more sensitive analyses. You can do time to event analysis instead of just alive or dead. You can do these treatment by covariate interaction tests and so on. So in this data set that we got from 10 randomized trials, which was published a few years ago in The Lancet, we had almost 8,000 patients, and we had a whole lot of events, 1,200 more deaths to examine. And this is the summary slide, and I know you can't see this from the back very well, but I put these helpful red boxes around them to show you in this forest plot that there is some heterogeneity of the treatment effect. This is age, showing it in the youngest patients. PCI did better, and in the oldest patients, bypass surgery was better. And the second box is showing you the effect in patients without diabetes and with diabetes. And the heterogeneity p-values were quite significant in this analysis. So this confirmed that if you just take pooled randomized trial data, you do see some evidence that there is heterogeneity in the treatment effect whenever you look at the individual data. So in this study, we found that diabetes was a very strong modifier. In the relative scale, the hazard ratio was 0.7 for diabetes and 0.98 without diabetes, which is a pretty big difference. And in the absolute scale, which may be more important for patients making decisions, the difference in 5-year survival between the two treatments was 8.5% or 8.7% in patients with diabetes and 0.5% in people without diabetes. So that's a pretty big difference too. Age also seemed to modify comparative effectiveness, another interesting observation. And we saw some signals in some other subgroups like people with peripheral artery disease and heart failure that were not significant because we just didn't have too many people with these characteristics in the trials. They weren't really enrolled, so we didn't have a very big sample of people with these kind of characteristics. Now, we've heard earlier today about the limitations of these trials and the questions about generalizability. Patient selection in these trials does limit the generalizability. They have fewer comorbidities. There's various groups that are underrepresented. And I'll just point out as an aside that if you didn't believe that there was heterogeneity of treatment effect, this wouldn't make any difference. Because in any sample then, if you saw the effect of treatment, it should generalize to everybody unless there really was heterogeneity. So implicitly we're saying when we're worried about generalization that in fact there may be important variations in how effective these treatments are in different populations. That's really the thing that underlies it. Well, there's other limitations too, as we know, is that the people who volunteer for doing these studies, the centers that do them are highly skilled, and especially with procedures like this, maybe we have the very best, the all-star teams for both treatments A and B, and if we had regular people doing them, maybe we wouldn't see the same results. And the sample sizes are just big enough to detect the main effect and not big enough to detect heterogeneity. And one other thing, and Rob is, I think he's still here, mentioned that the effect is supposed to be just little quantitative effects in randomized trials, but one of the things is by design we've eliminated people who we really thought truly benefited greatly on one hand or wouldn't get benefited at all on the other. So it's not so surprising that whenever we look at the forest plots within a trial that we see that they're all kind of around the mean, because that was a little bit of a problem by design. So we need more sensitive methods to pick up this heterogeneity is my point. So we did a study where what we wanted to do was look in observational data and see if we could replicate and extend the findings we had from pooling randomized trial data. So we wanted to look at a large group of patients who were in Medicare, where we have a lot of routine data that are collected in the process of care, and we used the Medicare 20% sample between 1992 and 2008. And we focused on patients who are at least 66 years old to give us at least 1 year of data to document comorbidities. We looked at people who had fee-for-service coverage so we could figure out what happened to them because of billing codes. And we focused only on multi-vessel procedures. We didn't look at single-vessel procedures, which we thought would be only really used for PCI patients. I probably need to spend a little more time on the methods here for this audience. We tried to, as some of the earlier speakers mentioned, emulate what the analysis would be in a randomized trial. So we tried to get a bunch of people who looked like they might be eligible for either procedure. We did propensity score analysis of all the patients in the data set to find a probability of getting CABG versus PCI. And we did propensity score matching, but we also forced in matches on the year that they got their procedure, whether they had diabetes or not, and their age within a year, because from other work, we expected to see differences in these factors, and we thought that there might be secular effects in the outcomes due to the year that the procedure was done. We looked for treatment by covariate interactions, which we had a number of pre-specified factors. And in the analysis, what we wanted to look at was heterogeneity in a couple of domains. We wanted to look at the relative differences, which are the hazard ratios, but we also thought that it would be actionable for patients to know what the absolute difference was in the chance that they'd make it to 5 years and how much longer they might live over that same period of time. So what we actually did here in this one line that says individualized predictions for the 105,000 patients, those are the number of people we had in each arm of the study. So after we developed a model, we fitting the data the best way we could to estimate the treatment effect, we went back in and plugged in everybody's individual characteristics from the start and artificially did the counterfactual experiment where we set the treatment variable to CABG and the treatment variable to PCI, and we just generated artificial predicted survival curves for that individual and subtracted the 5-year survivals, and we integrated under the curves to get the length of survival and see how much different they would be for the two groups. So what I want to do is present a little bit of the results from this kind of an analysis. And I'll say that this is just published this week in the Annals of Internal Medicine, and they wouldn't let us get it to you beforehand, but I'm sure that Claudia and her team can give it to you now if you want to get a copy of this paper. So what we found was that overall, bypass surgery patients had better survival. The hazard ratio was 0.92 with a pretty tight, whoops, I didn't mean to do that, with a pretty tight confidence limit. The 5-year survival is 74% versus 72%. But the important thing from our point of view was not to just confirm the overall effect, but to look at this variability. And in the hazard ratio dimension, we saw that there was substantial treatment effect modification. Diabetes, once again, had a significant treatment effect modification. But also, these were significant interactions with heart failure, peripheral arterial disease, and tobacco use. All of those were modifiers. And so if you looked at the individual level, there was great variation among people in the outcomes. And in fact, as you'll see on the next slide, we actually predicted about 40% of the population would have a better survival with angioplasty, even though the overall result was that CABG was better. So this is a histogram showing you, let's see if I can get around to the side here, the distribution of patients in the vertical axis and the amount of survival that, whoops, I just killed the whole thing. The amount of survival that they would have on the horizontal axis where this is more survival, and over here is 0, there's a little less. And what you can see, even from the back of the room, is tremendous spread in terms of the expected survival among the patients. So if you looked at all 105,000 patients, you know, they're all over the place. There is an average number, which you can see down here with the little dot in the box. That's the mean, and the median is here, the vertical line, but the 95 and 5th percentile you can see range from very, very widely, including a negative number. So this confirms the idea that there's substantial treatment effect heterogeneity that might affect people's decision making. So this is, I thought, an important result for that. And one of the questions is, can we pick out who those people are who get different results? So this is just some box and whisker plots for the major things that we found were predictors: diabetes, tobacco use, heart failure, and peripheral arterial disease, showing that when somebody had one of these factors, their predicted extension of survival was much greater than somebody who didn't have one of those factors. So these are the distributions. And you can see those are pretty, like for heart failure here, they're quite a bit different in terms of effect on survival. And we did say that, you know, you could take anybody in this and plug in the 7 variables and get various predictions out of it. This is just kind of a huge lookup table for our article with the results. You know, so for this particular patient, which I can't read here, predicted 3% 5-year survival, the range that we have confidence in, what the hazard ratio is, and so on. So you can come out with some individualized predictions based on a model of what might happen to people, which was based on either a trial or in this case on observational data. Just as a point of discussion, I think there is some evidence for heterogeneity of treatment effectiveness of this particular example of bypass surgery and PCI. We found it in pooled randomized trials. We found it in observational analyses. I was reassured by the fact that we've had, between these two different forms of analysis, broad agreement. Maybe you aren't, because maybe residual selection bias could have affected our results, especially in the observational analysis. And I would say that what we really need to do is work on ways to figure this out. We've spent a lot of time focusing on the overall effect, and we need to spend a little more time, I think, looking on how we detect heterogeneity. Thank you for your attention.
Thanks very much. Next is Anirban Basu. Anirban is at the University of Washington, where he directs the program in health economics and outcomes methodology, which has the acronym PHENOM, and he works in the interface of microeconomics, statistics, and health policy, just what we need.